Welcome. Welcome, everyone. Welcome to our first webinar of our heart disease prevention series. My name is Allison Badia, and I'm Dr. Tan's assistant, and I will be your moderator for tonight. We're so grateful that you can join us tonight and that you can start this path to learn about heart disease in the search and the pursuit of a healthy heart. Our keynote speaker tonight is Dr. Michael Ozner, and he will be introduced by Dr. Mary Tan shortly. If you have any questions for Dr. Ozner, please submit them through the chat and we'll address them at the end of the hour. Keep your eye out for any communication from us because in the near future, we will have another webinar with Dr. Mary Tan, where she will be the keynote speaker, and she'll tell us about ways of preventing heart disease from the traditional Chinese medicine perspective. Again, thank you so much for joining us. Here is Dr. Mary Tan. Dr. Tan, could you unmute yourself, please? All righty. It's our first webinar. There we go.
Hello, everyone. Welcome to our webinar program, Heart Disease Prevention. I used to work in a large provincial hospital in China as an attending physician, specializing in critical cardiovascular care in the emergency room and the ICU, treating patients with acute heart attacks, strokes, and heart failure by combining Western medicine and the traditional Chinese medicine, such as acupuncture and the classical Chinese herbal remedies. I have been practicing traditional Chinese medicine and acupuncture in Mali for 30 years. A large number of the patients coming to me present themselves with multiple diseases, and many of those diseases are related to cardiac vascular disorders caused by improper diet, lifestyle, and environmental triggers. In traditional Chinese medicine, we are more concerned with treating the underlying causes of those diseases rather than just treating the symptoms. About 6 months ago, I had the pleasure to meet Dr. Michael Ozner, who has been practicing cardiology in South Florida for 40 years. For the past 35 years, he has focused his practice on the prevention of cardiac diseases. He reached out to me to inquire about how traditional Chinese medicine treats heart disease. Unlike most conventionally trained cardiologists, many years ago, Dr. Ozner became interested in exploring the ways heart disease could be prevented from happening in the first place, so as to enable his patients to avoid a lifetime of dependency on expensive medications or the need for the risky interventional procedures. Over the past 6 months, Dr. Ozner and I had some discussions about the ways in which heart disease can be prevented and even be reversed from the perspectives of traditional Chinese medicine and the Western medicine. These discussions led to the decision to present this webinar on the prevention and the reversal of heart disease. During the past decades, a small group of physicians in the United States and in other countries began looking for alternatives to drugs and invasive surgeries to prevent and reverse chronic diseases, including heart disease, by holistic approaches. Dr. Ozner is a pioneer in preventive cardiology. He is a board-certified cardiologist, a fellow of the American College of Cardiology, a fellow of the American Heart Association, the past president of the American Heart Association of Miami, and the current medical director of wellness and prevention at the Baptist Health, South Florida. He is also the symposium director for cardiovascular disease prevention, an annual international meeting highlighting advances in preventive cardiology and dedicated to treatment and the prevention of heart attack and stroke. He is also the author of The Great American Heart Hoax, Heart Attack Proof, The Complete Mediterranean Diet, and The Heart Attacks Are Not Worth Dying For. We are fortunate to have Dr. Ozner with us today. I'm pleased to welcome him to share his valuable knowledge with us. Welcome, Dr. Ozner.
Thank you very much, Dr. Tan. It's a pleasure to be here. So let me share my screen and we'll get started. Okay. Okay, so thanks again. I appreciate it. And it's a pleasure and honor to be here. And tonight we're going to be discussing cardiovascular disease, namely heart attack and stroke, and how we can prevent these dreaded diseases. So this is my most recent book that I wrote, Heart Attacks Are Not Worth Dying For. And basically it's a groundbreaking new approach that, that I have been really in the forefronts of preventive cardiology to try to prevent heart disease. And this is what I'll be discussing tonight. And so this book, basically I wrote this to provide a roadmap, a very simplistic roadmap that people can follow to be able to, when they go to their doctor, when they go to their primary doctor or cardiologist, they know what questions to ask. And this book is on Amazon, and I certainly have received a lot of positive feedback, not only around the United States, but worldwide. Now, I'm going to start my lecture by talking about the leading cause of death, not only in the United States, but worldwide. And what is that? What is the leading cause of death? Well, you're looking at it right now. And what you're seeing is a ruptured atherosclerotic plaque with an occluding thrombus or clot. Now that sounds like a fancy term, but we're going to talk about atherosclerotic plaques tonight. And in a simplistic form, these plaques are nothing more than like a pimple in an artery wall. And as a pimple gets inflamed, it can actually rupture. And the plaque itself consists of cholesterol and fats, and it certainly can get inflamed, and a highly inflamed plaque can rupture. And if it happens in the heart, we have a heart attack. In the brain, we have a stroke. We can have peripheral vascular catastrophes. And if you think about it, it's really a major problem because the leading cause of death for men and women, as I said, but the annual mortality is really disconcerting. More than 800,000 deaths in the United States each year from cardiovascular disease, again, heart attack and stroke. And if you look at worldwide, we have over 18 million deaths from heart attack and cardiovascular disease on an annual basis. The cost in the United States alone is approaching $1 trillion per year. So I'm going to start out with this little clip that I want to show you. And I think this kind of tells it all. So I love that little clip because that's really what we're doing in cardiology. We wait till people fall through the cracks and having heart attacks and strokes. And then we call fire rescue and ambulances, and we try to bail these people out. And half of them don't even make it to the hospital. And those that do make it, their life will never be the same. So it's my opinion, and my opinion for many years, that we need to become proactive rather than simply reactive in the diagnosis and treatment and prevention of this dreaded disease that we call atherosclerotic cardiovascular disease. So the question then, and a very important question, is what is the root cause of atherosclerosis? That's the buildup of cholesterol and fats in the artery wall. What is the root cause of this? Because that's an important question. And you have to know what the enemy is before you can defeat the enemy. And I'm going to show you in the next slide what the root cause. And if you ask a lot of people, they would say, oh, it's diet, oh, it's lack of exercise, it's stress, it's a lot of things. But this is actually the root cause. Without this, you're not going to have a heart attack or stroke, even with secondary risk factors. And what are you looking at here? What you're looking at is a low LDL particle, low density lipoprotein, which has a protein called ApoB wrapped around it. Now that sounds really fancy and really complicated, but it's really not. These are simply round spherical structures that is packed with cholesterol and triglycerides and has a protein on the surface called ApoB. And the reason why this is so important is cholesterol and triglycerides, which we'll talk about, cannot travel in the bloodstream by itself. It has to be carried and to its destination. And so these particles, these ApoB particles, are the particles that can carry the cholesterol and triglycerides around the bloodstream. And they are the particles that can get into the artery wall if there's too many of them and create this process that we call atherosclerosis and atherosclerotic plaques, which I'll show you in a little brief video coming up. So I'm not going to make this overly scientific, but these are the basics. And if you look at what are the ApoB lipoproteins that can potentially cause a heart attack or a stroke or peripheral vascular disease, here is the ApoB lipoproteins. That's the most common one is LDL, low density lipoprotein. But there are others, as you could see. There's a lipoprotein called lipoprotein little a. 20% of the population has this. This is a hereditary genetic risk factor that you're either born with or you're not born with. Unfortunately, 20% of the population has it. And if you do have it, then you are at significant risk for an early heart attack. And it's very easy to diagnose with a simple blood test. You only need to get that blood test once in your life to know that you either have it or you don't have it. And what's important is that we now have treatment to lower LP little a. These lipoproteins are also the ApoB lipoproteins, and VLDL and IDL and chylomicrons. You don't have to remember all that, but just know that these lipoproteins can also sneak into the vascular wall and create havoc and create atherosclerosis, leading to heart attack and all the other vascular events. Now, what is this? These lipoproteins down here are a different animal. These are called HDL, or high density lipoproteins. And they don't have the ApoB protein wrapped around them. They have an ApoA1. Why am I even telling you this? Because this is the so-called good lipoprotein, the type of lipoprotein that can actually go into the artery wall and suck out all of the cholesterol in the plaques and reduce the plaques. And so basically what we are focusing on in our scientific endeavor to end this disease are the ApoB lipoproteins. And it's certainly going to be a major part of my discussion this evening. So what is the genesis of an atherosclerotic plaque that I've been talking about? Well, to make it rather easy to understand, this is a very quick 10-second video, and this will show the process. So coursing through the artery wall are these lipoproteins, these ApoB lipoproteins in yellow. And you're going to see if there's too many of them, like a traffic jam, they take the exit ramp right into the artery wall. And when they get into the artery wall, they get really modified, oxidized, and changed. And when you get something that is modified in any way, you call in these purple cells, which are the inflammatory cells. These are monocyte-derived macrophages. They're in there because they sense an enemy, an invader, whether it's a virus, a bacteria, or a modified lipoprotein. They want to destroy it. So they go in there and they gobble up these lipoproteins, and that forms the atherosclerotic plaque that I've been talking about, as you can see in the artery wall. So let's go to the next slide and see how we can transition to an acute heart attack. And that is really by looking at these atherosclerotic plaques. And within these atherosclerotic plaques, as you get a buildup of these macrophages, which gobbled up all of these cholesterol particles, what happens is eventually they die. It's a process we call apoptosis. And when it dies, it releases all this cholesterol and fat into this atherosclerotic plaque, and it creates this necrotic gruel, just like in a pimple with a pus. And as this becomes highly inflamed, it can suddenly rupture. And when it ruptures, you get a sudden clot that can form that you could see here, and it shuts off blood flow. And so when it shuts off blood flow, this can lead to a heart attack if it happens in the heart, a stroke if it happens in the cerebral arteries in the brain, and again, peripheral vascular catastrophes, which we also see. So given that as my initial introduction to this term cardiovascular disease, heart attack and stroke and peripheral vascular disease, despite our focus on healthy lifestyle choices, and to me, that's the most important thing we do, even though the ApoB particles are the root cause, what happens is that there are two ways that you could get these too many particles. One is by leading a flawed lifestyle, eating really a typical toxic Western diet, which is highly processed, calorie dense, and nutrient depleted. And I could spend 5 hours talking about that, as can Dr. Tan, but the focus tonight is on the root cause. So clearly, despite our focus on healthy lifestyle choices, as well as medical therapy and interventional procedures, the morbidity and mortality, the death rate from cardiovascular disease remains unacceptably high. And what we are doing is simply not working, despite all of this attempt. And really, the next slide is Albert Einstein, the famous Albert Einstein, who has said that insanity is doing the same thing over and over again and expecting different results. Well, in many respects, what we're doing in cardiology. We're doing the same old thing. And, patients come in 5 minutes, we give them, a little talk of go follow a healthy diet or go get some exercise. We are not proactive. And I'm going to discuss how we can become proactive to mitigate and in some cases eradicate this disease. So the first thing is everybody, because I hear this all the time, and I say healthy lifestyle, I'm all in on that. That's very important. We could talk about, and we'll talk about, a healthy diet and regular physical activity and avoiding pollution and certainly getting good quality sleep and no cigarette smoking and on and on and on. That's very important. But why not simply tell people, look, have a healthy lifestyle, and that's really all I need to tell you? Well, here's part of the reason why that doesn't work. So here's a patient who comes in to the office and he says, well, I've got a dog and I promise I'll get the physical activity, and what I'll do is I'll walk my dog 30 minutes every day. So here he is walking his dog 30 minutes a day on the treadmill, and while he's drinking a Coca-Cola, and there's his potato chips down there, and he's sitting and watching TV. And I'm being facetious by this, but this is basically the problem, is that people, even though we tell them to follow a healthy lifestyle, many of them do not. And that's unfortunate because it really and it starts with nutrition. We can certainly do so much good. This is another interesting thing, and that is, here's a guy on the left, Jim Fix. Years ago, he was a very, very well-known marathon runner. He wrote books. He was an exercise advocate. He dropped dead at the age of 53 of a heart attack. Well, why is that? If he followed a really healthy diet, he exercised, well, because it's not only lifestyle, it's also having the right genetics. And that means that if you get hereditary risk factors that give you a high cholesterol, a high LDL, or a high Lp(a), or all the other things that I talked about, despite following a healthy lifestyle, you're going to have an early heart attack. So really, there's two things that we have to be cognitive of as physicians. One is making sure our patients follow a healthy lifestyle. And number two, making sure that they don't have a hereditary risk factor that really can lead to early and premature death. And the reason is because today we could do something about it. We could certainly, in the person who's just totally non-compliant with their lifestyle and has high ApoB particles or LDL, we know how to lower that today. And sure, we want them to follow a healthy lifestyle, but for those that don't or can't or won't, we're not going to leave them out in the woods to have an early heart attack. We're going to treat them so as to eliminate these plaques. And for those people that have the hereditary risk factors, we do the right blood tests on all our patients. We can measure the ApoB levels. We can measure LDL. We can measure triglycerides. And once we have these measurements, we know how aggressively to treat these people in order to keep them out of the hospital, out of the cath lab, and out of the operating room. And so, and before I leave this slide, who is this guy on the right? Sir Winston Churchill. Now, Sir Winston Churchill, who was the Prime Minister of the UK during World War II, he literally broke every tenet of a healthy lifestyle. First of all, he was under tremendous stress. He smoked. He was obese. He had all the risk factors in the world, but he lived into his 90s. Why is that? Because of his genetics. He was lucky enough to inherit. We can have gain of function. We can have loss of function. Mutations that could either make us have premature heart attacks, or people can live very long lives despite a flawed lifestyle. This is exactly why we need to get the biomarkers, the blood tests, to see. You cannot look at a patient and say, John, you look like you are going to live a long life, or Henry, you look like you're going to have a short life, or Mary or Jane or Susan. You can't look at somebody. You have to measure the blood test to see where they are, because that's how we then are able to regress, to stabilize, and as I said, in many cases, to eradicate these atherosclerotic plaques. Well, another question for a lot of people, they say, well, why not put everybody on statins? And for those of you that haven't heard of a statin, they've been around since the 80s. These are medications that were developed that can lower LDL cholesterol, great medications. This was really a groundbreaking new advance in cardiology. But the problem with statins was that, yes, they lowered LDL and they lowered ApoB, and they certainly lowered cardiovascular risk of heart attacks, but they only lowered it by 25 to 35%. Well, that's great, but what about the 65 to 75% of those taking statins that go on and have heart attacks? What do we do about them? Well, I'm proud to say, and I'm pleased to say, I've been in this space for, as Dr. Tan said, for 4 decades. We are now at the dawn of a new era in cardiovascular disease prevention. And this is an era where we can actually take this ferocious lion that we call cardiovascular disease and reduce it into a harmless pussycat. And that's what I'm going to discuss in the remainder of my lecture. So I'm calling for a new paradigm shift for cardiovascular disease prevention. It's now time to consider intensive lipid or cholesterol, triglyceride lowering in younger and early midlife adults to eradicate or eliminate early stages of atherosclerosis, thereby eliminating the risk of developing cardiovascular disease events later in life. And again, I'm not going to go through this because I showed you the videos, but here is basically how it works. You get these lipoproteins that I talked about, the ApoBs, they're gobbled up by these macrophages. They become foam cells, they eventually die and release all the necrotic gruel that I like to call it, which are, they have cholesterol, fats, there's inflammation. Well, if we lower the influx of these ApoB lipoproteins, we could get a efflux or a movement out of the vascular wall. And we get macrophages that instead of gobbling up these particles, they go into the plaques and they are able to gobble up the debris and leave and emigrate to the regional lymph nodes. In other words, you go from macrophages that are part of the problem by contributing to the atherosclerotic plaque to what we call healthy anti-inflammatory pro-resolving macrophages that lead to a cleanup. That is a process we call efferocytosis. Now, I can tell you that the way to affect this and to achieve this is, first and foremost, we have to be able to get a significant lowering of the ApoB particles, whether they're LDL, IDL, VLDL, LP(a), doesn't matter. We have to lower those particles. And when we get the ApoB levels down, the LDL level and the others down, we start to make a cleanup of this process. Well, the question that all of you, I'm sure, have had blood tests and you've had cholesterol measurements. What is the optimal cholesterol level, the LDL level? And, because for years we've been hearing, well, if you get your LDL below 100, that's fine. And well, we're happy your LDL is 85 or it's 90. Well, no, I've never been happy with that because we're still getting cardiovascular disease. We're still getting deaths of younger people and older people. And so really the normal, this was a great article written by my friend and colleague, James O'Keefe, that a normal LDL cholesterol is in the range of 50 to 70. And that is for hunter-gatherers that are still on this planet, newborns, free-living primates, wild mammals. All of them have levels that are in this range, and none of them develop atherosclerosis. So that's pretty solid evidence that if you walk around with levels in normal range, you certainly can beat this disease of atherosclerosis. There's no reason, it's not a disease that as we age, we must get atherosclerosis. That is completely not true. So this points out a very interesting study in a certain tribe, a hunter-gatherer tribe that's still around on this planet in the Bolivian Amazon. And these people, they basically are physically active. They're hunting every day with a spear. They fish. They grow vegetables. And there was a study where people noted that they didn't have heart attacks. Very few. It was almost unheard of for them to have heart attacks. And they found out that their coronary calcium scores were almost zero, even in the 10th decade of life. And the conclusion was that this was the lowest reported levels of coronary artery disease of any population to date. They were walking around with LDL levels down into the low 50s. And so, and by the way, the average American walks around with LDL levels over 100, more than double of this. And so the way to, the winning strategy is achieving a lifetime with low LDL, low blood pressure, low blood sugar, normal body mass index, no smoking, non-processed food, and plenty of physical activity. So the causal role, and I'm going to go quickly on some of this. And again, that, you know, anything that you miss, you want to go back. I have it all chronicled in the book with at the end of the book, at the end of each chapter, I have the key points. And it's as I say, it's an easy read. And this is important for you to understand this. But what we need to do, and this is shown by Wolf and his colleagues in loss of function mutations that resulted in people having very low LDL levels. And guess what? They lived a long and healthy life, free from atherosclerotic cardiovascular disease. So we know that getting these numbers down is very important. And here's a good visual. Here's a patient who had chest pain, and he underwent a heart catheterization, a coronary angiogram, and you could see his coronary artery, one of his main coronary arteries, came down here, left anterior descending, and you could see the narrowing of this artery. Well, that's all that atherosclerotic plaque that I showed you. And so he was treated very aggressively with aggressive lifestyle intervention. And you can see a year and a half later, a complete eradication of that plaque and a return to a normal looking coronary artery. So this is exciting that we can achieve not only regression, but complete eradication of these atherosclerotic plaques. We should be shouting this from the rooftops. And in many respects, we're not doing that. And that's why I'm so passionate about this, because we need to get this message out, not only to all of the people around the world, both men and women. And may I add that women, don't think that heart disease is a man's disease. It's the leading cause of death for women as well. We need to get this message out. And certainly we also need to get it out to all of our medical colleagues as well. And we could see that we have a term in cardiology, and it's called lower is better. So the lower we get the LDL cholesterol, the lower we get ApoB particles, the lower will be CHD events. CHD stands for coronary heart disease. So, you know, that is, there is no lower limits, by the way. Lower is better. And so that was primary prevention. Secondary prevention means people who have already had heart attacks. The same thing applies. Just because you have a heart attack, or just because you have a blockage in your artery, one of these atherosclerotic plaques, doesn't mean that we can't treat this as well. Because what we know we can do in these plaques is get that LDL down very low, get all the other lipoproteins down low. And by doing that, we can actually achieve plaque regression, which means a shrinking down of the plaque, as well as plaque stabilization, because a stable plaque will never rupture. And if it doesn't rupture, it won't hurt you or kill you. So this becomes a very, very important. I could talk about this all night long. The bottom line is that what is it now that is different from the past? what do we have now that really is has been a game changer? And that is, I like to say that we have new arrows in our quiver to lower atherogenic lipids, these LDL particles and the ApoB particles. We have new and better ways of doing that. So here's the statin medications that I talked about. And again, this is, I always tell patients, start with lifestyle, start with a healthy diet, start with exercise, all of that. We'll remeasure your lipids. We'll see what your LDL is. We'll see what your ApoB is. But if they do all of that and they still have elevated levels, we now have more arrows in our quiver. And here's all the other arrows. We have drugs that are, statins are cholesterol, that inhibit cholesterol production. Ezetimibe inhibits the cholesterol absorption in the GI tract, and on and on. We have bempedoic acid. We have these drugs called PCSK9 inhibitors, and this has been a major advance through genetic engineering that we've had development of these agents that allow us to get to the promised land. That's getting these levels of LDL and the others down to levels where we can achieve regression or shrinkage of the plaque, where we could clean out the arteries, just like I guess you can clean out your pipes at home by putting Drano in there. We can now clean out the pipes in our body by lowering LDL and all these other toxic lipoproteins and allow this efferocytosis process to achieve a cleanup. And we know that if it happens early, because there's not only lower is better, but earlier is better. If we could do this early in life, we could take the soft plaques that are out there and we could completely eliminate them or eradicate them. And that's a powerful statement. So this is exciting news that we now have the tools to be able to do this. These are some of the new drugs. I'm not going to spend much time. Again, it's in the book. If you're interested, evolocumab is a PCSK9 inhibitors. Two things I want to point out. It was able to get the LDL levels, the mean LDL levels down to 30. Think about that. The average person's walking around over 100. We could get that down to 30. When we get low levels like of that, we stabilize plaques. We shrink the plaques. And as I said, in some cases, when we don't have a heavily calcified advanced plaque, we can actually eradicate these plaques. The other thing about these studies that were done with these drugs, it's safe. Because not only is it important to show efficacy, but it's equally as important to show safety. And that's what's so important. Now, this drug right here, the next one is called inclisiran. This will really be a game changer. This is a PCSK9, and it has been developed. It has been approved in Europe. They're using it in Europe, and it's in the European guidelines. In the United States, I suspect that it'll be approved in the near future, because what makes this so much of a game changer is this drug has will result in a significant lowering of LDL cholesterol and the other atherogenic lipoproteins that I discussed. But the amazing thing about it is you only have to take it once every 6 months. Think about that. So the patient comes in the office, it's given by sub-Q injection. It's been shown to be safe, and it will lower the LDL and the other atherogenic lipoprotein, but especially the LDL, down to levels that we haven't seen before, and do it safely. And you only have to come in once every 6 months, because a big problem we have by putting people on statins or these other medicines is compliance. You know, they'll take it for a month or 2 months, they'll forget to take it, they won't take it. They're coming into the office, we give them this very safe and effective sub-Q injection, and we protect them. So to get further lowering, we could get further lowering beyond a statin of up to 20% with ezetimibe, another 20% with bempedoic acid. There's now a combination of ezetimibe and bempedoic acid that can get them down to a 40% drop in the LDL. The PCSK9 inhibitors, significant, up to 60% reduction beyond what we can get with ezetimibe. We are in a brave new world, and this can lead to complete atherosclerotic plaque regression, or in many cases, eradication. Is achieving very low levels of cholesterol safe? You betcha. And this certainly is a study of people that have mutations that result in very low LDL cholesterol levels, and they live long, healthy lives free of atherosclerosis. How about the brain? People were concerned, well, if you get cholesterol down that low, can it cause cognitive dysfunction? Well, this was the Ebbinghaus trial that was published in the New England Journal of Medicine that shows that no, there is no cognitive function abnormalities of these powerful new agents, which is, that was an excellent trial. So I like to say that as it relates to LDL or ApoB, that lower is better, but lower earlier is best. So the earlier in life is best. And early intervention to profoundly lower LDL cholesterol and ApoB can substantially reverse and even eradicate early stages of atherosclerosis. So where does this process start? It starts in childhood. And actually, almost all children following the typical Western toxic American diet have fatty streaks in their aorta before they hit age 10. And we know that atherosclerosis, this process that I've been showing you, can develop in late adolescence or early adulthood. And this is a telling trial. This was a clinical trial that looked at soldiers killed in the Korean War, and they did 300 autopsies. Mean age of these soldiers who were killed was 22 years old. Almost 80% of them had evidence of coronary atherosclerosis. This is a disease that starts young, and this atherosclerosis and these atherosclerotic plaques will fester and be there for decades before they raise their ugly head and rupture and cause heart attacks and strokes and the like. So I think that it's very important. Imaging, I'm not going to spend a long time on this other than to say that we have very good imaging with like CT angiography that could determine how many do you have plaques in your coronary arteries. But what I really like is ultrasound because it's simple, it's inexpensive. We can do it in 10 minutes. So take a look at the arteries that we can image just by taking an ultrasound probe, and they're now portable, and looking at the carotid arteries in the neck, the aorta, the femoral arteries and the lower extremities, and we could see is there atherosclerosis. Because if we do this and we find, and especially in young people, young to middle-aged people and beyond, we find that there's atherosclerotic plaque, we now have the tools to be able to significantly lower their LDL cholesterol and the other lipids to be able to eradicate and eliminate those atherosclerotic plaques. So as I say, we're in a brave new world. This is an ultrasound of carotid artery. Here you see a soft plaque. This is a patient who was treated aggressively. Follow-up ultrasound showed complete eradication of this plaque. This is how we become proactive, not waiting for these plaques to rupture, not waiting for somebody to show up in the emergency room with a heart attack or a stroke and then trying to bail them out. So we know now is that the paradigm shift is to eradicate atherosclerosis before it becomes more advanced and associated with major adverse cardiovascular events. And in reality, this is what the gastroenterologists have been doing for years. They've been 3 steps ahead of us because when they do colonoscopy on a patient, what they're looking to do is to find these polyps that can progress and form cancerous polyps, but they go in there and every 5 to 10 years, they'll do a colonoscopy and they'll snip them out before they become cancerous and invasive cancer. And that's really what we should be doing in cardiology. We should be intervening before we have disasters, not waiting for that time and becoming reactive. So what is the future? The future is residual risk factor control, doing all those things that we know work, from lifestyle to controlling blood pressure, controlling inflammation, controlling diabetes and insulin resistance, controlling weight, and certainly doing everything we can to control obesity, and then lowering cholesterol And again, all of this is in the book. I'm not going to, spend much time on this. We've already gone over a lot of this. To lower LDL, we can lower triglycerides, lower lipoprotein little a. And by the way, the question also comes up, if we're able to do this now, do we really need to be doing all this surgery and intervention in patients who are stable? Now, let me make it perfectly clear that people who are unstable, people who report to the emergency rooms and the throes of a heart attack, that's where intervention and putting in stents, sometimes doing bypass surgery is not only important, but it can be life-saving. But how about in the stable person, the person who really is just in your office, but happens to have a blockage, but otherwise they're occasional chest pain? I think we're going to have a change and a paradigm shift there, because rather than taking these people and putting in stents in the stable population or doing bypass surgery, many of these people we could treat aggressively to shrink and in some cases eradicate these plaques so as not to have to send them to the cath lab, to the operating room. These procedures are not without risk, and they certainly are expensive. I think this is going to be really a approach that this prevention approach that makes much more sense in the stable population as well. So the new approach that resets the vascular aging clock is composed of initial regression therapy and then retreatment as needed to be able to suppress atherosclerosis. And in conclusion, in my lecture tonight, clearly atherosclerotic cardiovascular disease, which is the cause of heart attacks and strokes, is the leading cause of death for men and women worldwide. Controlling these atherogenic lipoproteins that I discussed with lifestyle intervention and medical therapy, especially the newer agents that I discussed, can prevent, stabilize, and regress atherosclerotic plaques. That early intervention is key, and that eradication of atherosclerosis is an achievable goal. And my final slide is, so what is the road that we should be walking down? Is it to be doing the same old thing that we've been doing? No, I think we should walk down not the dead end road, but progress road. Progress road is to have a healthy diet, get regular exercise, avoid stress, avoid smoking, get the biomarkers that I discussed from LDL to the lipoprotein little a to the VLDL particles, and certainly getting ApoB, which is a measurement of all of those, so that we can determine is a patient at risk. And if the patient is, despite doing all of the lifestyle intervention, we have pharmaceutical approaches that can allow patients to get regression or shrinkage of these atherosclerotic plaques, and in many cases, be able to eradicate them, so as to live a long, happy, and heart-healthy life. Thank you very much for your attention.
Thank you, Dr. Ozner. Woo. I am digesting all this information. This is great. And I see that our participants are also going through a similar process. I'm reading a question here from Dr. Wei, where I think she was asking if there is one test to, I guess, measure heart disease risk. I know that we spoke about you spoke about ultrasound, but we were wondering, is there another test name?
Yeah, so the first answer to that question was there a test, and I would say step number one clearly is getting the blood tests. Those are the biomarkers. You have to get that. You can't guess about that. And I think that all the major labs, Quest, LabCorp, all the major labs do all these, a standard lipid profile that we've been doing for years and years, decades. And so it's inexpensive, and everybody should have a standard lipid profile and consult with their treating physician, because that's really where the money is. And and I go beyond that. I like to get an ApoB level. Then I've discussed the ApoB tonight because certainly that is now relatively inexpensive, covered by insurance in most cases. And I also will get an LP little a on patients. Like I said, you only need to get that once. But if the patient has an elevated LP little a, you need to know that because we can now do something about it. As far as imaging tests, as I mentioned, yes, there is one test, and that for looking at whether there is buildup of this atherosclerotic plaque in the coronary arteries is coronary CT scans. We call it CTA, coronary CT angiography. And it's a terrific test. We can measure plaque burden. We could do a lot of things. The problem with that is, are all young people going to go in there and get a test that's somewhat expensive, gives you radiation exposure, and it certainly, that is the reason why I think that I reserve that for patients who are in the emergency room that need it, or for people that are at risk. And I think it's a terrific procedure. The radiation exposure has gone down over the years, and the cost has gone down, which is good for CT angiography. But ultrasound, I really like. Ultrasound is something, but we have to get this out to the masses. This is something you can have a handheld ultrasound as a treating physician, and it's really relatively straightforward and easy to use. You go into you look at the carotid arteries, you look at the aorta, you look at the iliofemoral arteries, the peripheral vascular disease, to looking for peripheral vascular, you're looking for atherosclerotic plaque. And if you find it, then that is something that is, I don't care whether the patient follows a healthy diet, what they're doing, if you're seeing on image that they have atherosclerotic plaque, they need to be treated aggressively because we can eradicate those. And the earlier you do it, the more likely it is we're going to completely get rid of it. But remember, even those that we can't get completely rid of the plaque, we could still shrink it down and suck the inflammation out of the plaque by doing the things I talked about tonight, so as that plaque won't rupture.
I see. Thank you so much for that. We have another question coming through from Itsu. Does cholesterol, specifically LDL, play a role in sudden cardiac death?
That's a good question. And the answer is yes, because if you have too much LDL cholesterol and you develop a heart attack, that's one of the frequent causes of sudden cardiac death. Because when you all of a sudden block off an area of the heart because of a blood clot that forms in one of the coronary arteries, and that heart is now suffering because it's not getting enough oxygen and it's not getting, normal blood supply, often that will be the trigger for ventricular fibrillation and sudden cardiac death. So yes, in that respect, LDL can be a causal agent by causing the atherosclerotic plaques and for those to rupture. And then we also know that if we can reduce the risk of heart attacks, by default, we are significantly lowering the risk of sudden cardiac death. There are other causes of sudden cardiac death, genetic causes and things but one of the major causes, what I talked about tonight, which is atherosclerotic cardiovascular disease. And if we can eliminate that, we can certainly eliminate, in many cases, sudden cardiac death.
All right. Another question from Elizabeth. What is the best current treatment to lower LPA?
Okay, another good question. So, it's right now, we unfortunately, there are conventional medications like statins and ezetimibe and the other that I talked about did not have any impact on LP little a. So, but now we have the advent of those PCSK9 inhibitors that I talked about, lowers LP little a by about 20%. But really, the exciting thing right now is a trial which we call the Horizon trial, using a technique called antisense technology. And basically, it's a new way of lowering the Lp(a) by up to 80 to 90%. That's very exciting. It's in phase 3 clinical trials right now. Because we know it works. We know it lowers Lp(a). We never had anything that was able to do that. No medication be able to do that in the past. But we have to also show before it's going to be FDA approved that it'll also decrease cardiovascular events. My guess is that it will for sure, because we know that Lp(a) is a very highly atherogenic particle. That means that it's a particle that is very easy to get into the artery wall. It's very highly oxidized, and it's very likely to contribute to heart attacks and early death. So I'm banking on the fact that this new approach of by using antisense technology get a profound decline in Lp(a) is going to be a game changer for people who have that disease.
And one last question. If you could explain to us a little bit more about why stent and bypass surgery and why those cannot solve the root problem.
Yes, and that's a good question, because when you think about it, and like I said, I want to be very clear about this. I feel that patients who are unstable, clearly stents, by opening up an occluded artery, or they have left main occlusions, and we have all different scenarios where stents and surgical intervention in some patients, bypass surgery are essential. They, like I said, the highest respect for interventional cardiologists and cardiac surgeons. They save lives on a daily basis. But I will say that if you put a stent in a patient and you don't do something about the root cause of what got them there in the first place with that atherosclerotic plaque, they'll be back. They'll be back for more stents, they'll be back in the emergency room with more heart attacks, because the stents don't do anything to the what I showed tonight, which is the buildup of this atherosclerotic plaque by too many of these harmful, toxic atherosclerotic agents, so these particles that get in there and cause the problem. Stents are kind of like a Band-Aid, and a very important Band-Aid in the unstable individual. But if somebody has to have a stent, they certainly need to be treated and followed by a preventive cardiologist who's well-versed in what I discussed tonight, so they could lower the atherogenic lipoproteins so that they don't come back for more interventional procedures. And like I said, some of them won't even make it to the hospital. So I think it's critical for those individuals who have had intervention not to walk around thinking that they're fixed, that they're cured. These are individuals that certainly have been many times saved from sudden cardiac death, but then it's time to roll up your sleeves and get out all the prevention tools so they won't be back again. I like to say that the person who goes to the hospital with acute appendicitis, when you're the doctor wheeling George or Mary out of the hospital, you can say, I've cured you, I fixed you. You will never come back to the hospital with acute appendicitis because your appendix is now in the pickle jar. But you can't say it to the patient who has just had a stent or bypass operation, that I've cured you, I've fixed you. Unless you do something about the very cause of what got them there in the first place, they'll be back for more intervention. And that's why I think that this approach is so important today, that we start becoming more proactive rather than simply reactive in our treatment of atherosclerotic cardiovascular disease.
Okay. I actually see another question sneaking through in the chat. if you're up for it. I know we're on time to finish up, but this could be a quick one. Would echo be helpful in detecting atherosclerosis?
Yes, there's basically, we have echo to be able to, as I said, look at the carotid arteries, look at the aorta, and look at the iliofemoral bed. So yes, echo is very important. And we now have not only two-dimensional echo, we have 3D echo that can measure a plaque burden. So we've come a long way with echo in terms of looking at plaque where we could see it. Conventional echo, we cannot see the coronary arteries, but we can with intravascular ultrasound, but that's an interventional procedure. And so really the important point as far as echo is concerned, if you see, it doesn't just hit one vascular bed. You don't get a plaque in in one bed and that's it. It doesn't just focus on a coronary or the carotids or the femoral artery. If you see it in one vascular bed, you know it's all over the body. And so that's a sign that, okay, the person now has atherosclerosis that is in a vascular bed. Let's treat them aggressively to clean out their arteries, if you will. And then after you do this, you can then, and this is in addition, always in addition to lifestyle intervention. But, hopefully it doesn't necessarily even mean that somebody will be on high dose medication for the rest of their life. They can then maybe be more aggressive with their lifestyle to keep that away and get follow-up ultrasounds as follow-up lab looking at their atherogenic particles and be able to, that way we could see patients, we could basically get them free of atherosclerotic cardiovascular disease, and then treat them aggressively when we need to, and then go to a more conservative approach when, once we get them to where we want, based on biomarkers, based on risk factors, based on many other things. And that, I think, is going to be the approach going forward, not only throughout the United States, but worldwide.
Thank you so much, Dr. Ozner. We really, really appreciate your time and sharing this information with us. I love that you wanted to recap a little bit on lifestyle. And I want to make sure that our participants know that we'll be touching a little bit more on this in our next webinar. So if you have any questions, you can email us at drmarytan@yahoo.com. If you want to become part of our email list so you know when we will be meeting next. Again, thank you so much, everyone. Thank you, Dr. Ozner and Dr. Tan. I hope you all have a beautiful night.
Thank you very much.